Welcome panelists, welcome attendees. Many thanks for joining us today on the Digital Health Institute for Transformations podcast and web series, the DHIT Frequency, where game changers, status quo challengers, and transformers come together to share, explore, discuss best practices, next practices, and all else in the digital health space. I'm Michael Levy, DHIT's president and your host today. I want to first thank our sponsors for supporting our mission to maximize health in communities across the nation and beyond by providing equal access to global advancements in care and believing in our vision of enabling a world without health inequity.
Thank you to our sponsors. Thank you to Blue Door Group, a leading digital health agency supporting growth and product innovation through customer and market insights. Thank you to Tanjo, a powerful human-powered neural net that is the optimal combination of human and machine intelligence to help people achieve the right balance between humans and automation to optimize outcomes. And finally, Smashing Boxes, a creative technology firm with a strong emphasis on the design and engineering of web and mobile products. Visit our sponsors today.
It's with great pleasure and mixed emotions that we launch our web series during this time of tragedy and global calamity. What a couple of weeks it's been, to say the least. First of all, our thoughts and energy go out to all those on the front lines of this pandemic, to those who are fighting for their life, to those who are fighting to save lives, and to those who are fighting to feed their families and keep shelter over their children and families as well. We are here with you. Panelists, it appears now more than ever, digital health is front and center to support and progress through this COVID-19 pandemic. There's undoubtedly a massive adoption curve occurring in the use of digital health. The rise and prevalence of telehealth is minimizing our need for in-person visits and allowing for continuity of care, like what we haven't seen before. Conversational bots that evaluate symptoms and triage patients are helping to alleviate some of the burden from front lines. And advanced analytics driven by AI is isolating clusters and tracing contact to support prediction and proactive intervention. We're going to be discussing today with our distinguished panelists their respective and prospective health systems and communities and how they're navigating this crisis with the help of digital health today. But before moving in and jumping in and introducing our panelists, I just want to reach out to the audience, say thank you for joining us, request your participation. There's a Q&A section at the within Zoom. If throughout this panel you send in your questions, you have the opportunity to upvote, like the questions coming in, and we'll source them. Those one that get the greatest likes on the back end of this panel, about 40-45 minutes, we'll pick a couple and we'll tee them up for the panel themselves. Without further ado, it's a great pleasure to introduce the esteemed panel. One note, we have a panelist that is unfortunately battling right now on the front lines at the University of Montreal Health System and in Montreal, Quebec. Kathy Mollis, Associate CEO, Head of Innovation and AI for the University of Montreal Health Center, is not able to join us today. She sends her regards. She did indeed respond to a number of preempted questions, and so we'll sprinkle Kathy and Kathy's thoughts and the work that they're doing at the University of Montreal Health Center throughout this discussion, but she is not going to be with us today. That said, we do have Angela Yochem, Executive Vice President, Chief Digital and Technology Officer for Novant in North Carolina, US, and Dr. Sujoy, Chief Medical Information Officer for Apollo Hospitals in India. Thank you both for joining us today. It's a great privilege, very humbled for the hour that we get to spend together, and incredibly excited to hear your perspectives and your thoughts on our moment in time, where digital health is today as it relates to the past and perhaps what it sets us up for in the future. And that, of course, taking light of our current situation, this pandemic that is real and that we're all battling through as we speak. Angela, Sujoy, thank you.
Thank you, Michael. It's great to it's great to stay connected in this way. Thank you for taking the lead on making sure the community stays together to talk about digital health.
Thank you, Michael. Thank you for inviting me. I know I've missed a couple of your previous programs, but I don't want to miss this one. We are going through exceedingly difficult times world over. And as a community, as a citizen of the world, we will all respond to it. Make no mistake.
Well, thank you for being leaders, both to your health systems and to your community, as well as to the DHIT ecosystem. We are, as I said, a community of game changers, status quo challengers, and health transformers with the intent of servicing our communities, one community at a time. To help us understand those that have been in lockdown, those that have been in quarantine, which is much of us across the world now, that aren't on the front lines, that aren't connected to the hospital health system per se on a day-to-day basis. What is, Angela, maybe we could start with you and then Sujoy, what's the environment like right now? What's the energy that you're feeling, and how are you maintaining that calm, that optimism day in and day out as you're waking up to this variability and this new norm?
We are, I think we can broadly classify the sorts of things that we're doing now with extreme urgency into two broad categories. One would be preparing for a large influx of COVID-19 patients and optimizing to support their needs. There are many, many things that go into that preparation. There is a tremendous amount of advanced modeling that's happening so that we can know what to expect across the regions that we serve. There is, certainly a staffing element. There are supply elements. There are all the things that you can imagine that are happening. That are, we are doing everything humanly possible to be as prepared as we possibly can to serve the communities as we have in the past, but under tremendous strain. So that's one part of what we're doing. And the other part of what we're doing is trying to keep and serve the communities, keep the communities healthy. So we've, as has everyone, we've canceled elective surgeries. We want to be able to provide care to the patients in their homes as best we can. And to that end, we, and this, as you mentioned, this is providing, screening bots on our website. This is pop-up screening centers. This is, providing information. This is digital health capability. In the last couple of weeks, we've had over 50,000 virtual visits with our patients. And, the tremendous appetite that exists is, has been extremely gratifying. To know that, we have a virtual health capability that is fairly sophisticated, and that there is an appetite not just in the patient community, but also in the provider community to engage using these platforms. It's wonderful to see, and it's helping keep our communities healthy at a time when people are unsure of what the future holds. So those are the two broad categories of things that we're focused on doing today.
Thank you, Angela. Sujoy, give us a sense from India, from your part of the world. And my understanding is India, just about a week ago went into full lockdown. 1.3 billion people. What? Give us a sense. Are you mirroring this? Are you seeing and experiencing slightly different levels of engagement and or actions? Give us a sense of what it's like.
Yeah, Michael, it's just getting started here in India, if I put it this way. Till now, around 2,500 people are already infected, about which we would have had around close to 150 people in hospitals in one form or the other. And we have had about close to 60 people dying of this of this virus. So we are geared up. In Indian context, I have to put it that we are always having, you know, the kind of population that we have, the susceptible population that we have, and many of us would know also India as a capital of non-communicable diseases, preconditions, which are now, you know, at a point of vulnerability. If you have a disease like COVID, COVID at this point. And therefore, you know, there are pretty good steps that the government have taken. One of the things that have been going on with the government for past 20 years got signed up in about 20 hours. And this is about the Indian telemedicine guidelines. The government finally approved the telemedicine guidelines in March 25, on the 25th of March last week. And it talks about all the right things that we need to do. Evaluate and manage patients from a distance, particularly in a time of this kind of crisis, without exposures, reducing risk, talks about rapid access, and then provides a whole lot of extra working hands and do a lot of in-depth triage. At Apollo Hospitals, what we have been able to do, we run already in India's one of the largest telemedicine networks covering about, you know, 350 telemedicine units across the country. We, of course, are 75 hospitals, over 10,000 beds and all of that. But in addition to this, what these telemedicine units are doing for us is actually reaching to the last mile, talking to the people who actually require the care at the remotest of places. So to give you an example, we have now telemedicine centers in the foothills of Himalayas, where only, you know, people who trek can reach, right? And then you start treating them or covering them. And yes, we do have cases around those areas as well, going into that. The other very important thing, so I'll just quickly talk about a story. This is about a 65-year-old lady who had a eye surgery about, you know, 4 months back. And she, you know, somehow reached out to me saying, I have started having pain in my same eye for the last 48 hours, and I don't know, son, what to do at this time. So what we have been able to do, and I got in touch with our telemedicine department and the health and the hospital. She was flooded by 4 calls in a span of, you know, 15 minutes with people asking her from the hospitals, you know, what can we do for you? Should we come to your house? Should we bring you to the hospital? Her daughter stays in Australia, right? And she stays all alone. So that is the kind of bonhomie, that is the kind of community connect that we would need to do at this time of hour across the world.
So, I mean, I love the story, and that sounds like a wonderful service-oriented system that is really connecting to the emerging and you know, explosive consumer wants and need, as well as to meet the patient where the patient is. You mentioned your policy changes, and Angela, I'm going to come over to you from the U.S. perspective here in a second. But what it seemed like technology is not the issue. The technology has been there to reach the Himalayas and the broad you know, remote places in India. You know, you mentioned a barrier that took 20 years. But in 20 hours, people and processes reoriented our ability to service. Is that fair to say?
Exactly. You know, there were a lot of thoughts about that. You know, people were actually arguing about privacy, about confidentiality, about, you know, how the records around telemedicine would be kept and who owns them, and a whole lot of things that were around this. But come at the hour, come at the solution. You know, this is possibly, you know, not the right thing to put it that way, but probably it was waiting for something like this to actually, get through the bureaucracy and say, hey, look, we are now adopting to these challenges. But having said that, there are a few challenges that we still face in this country. One is, of course, we have is it has to be now adopted by the doctors or the physicians at large. And this is something which is going to be very, very important. Then, of course, we have to also see, how it is bringing in multiple other stakeholders into the platform. Hospitals, of course, I spoke about physicians, other healthcare workers, somebody like a dietitian, physiotherapist, and all of that. Pharma, insurance, regulatory agencies, and all of that. And then ultimately, we will start talking about device integrations. We'll talk about AI integration as well. Finally, to put that word in India or world over, what we feel, having used AI integration into our systems, we would always go to that level where we see AI plus clinicians, right? As a solution to start with, rather than to take another 20 years to reach that level.
Right. Thank you, Sujoy. Great perspective. And now shifting to the U.S., shifting to Novant. Let's take a look, Angela, in both the kind of similar vein from a policy, regulatory, cultural acceptance and/or acceleration of, and what we're seeing here now, but also anchor and drill down from a Novant perspective what you and your team has done in the last 18 months or so with understanding where talent, where the development of people and operating processes needed to mature to adopt these technologies and get to the place where AI plus human are interacting with the focus of right patient, right place, right time mentality.
Thank you. So there are a few topics there, right? So first, I'd like to I think I need to recognize that in the United States, our payer community has stepped up during the COVID-19 crisis, as they always do, and they have started to reimburse virtual visits as they would a physical visit, which is extraordinary. Because of that willingness to support virtual visits, we're now able to provide access to care through virtual means in a way that isn't putting undue stress or expense on our providers or on the patients themselves. And so that's been tremendous. Virtual visits, as you know, are it's about providing access to care for people, not only in rural areas who might have to drive 45 minutes to get to their nearest primary care physician, not only in urban areas where someone may have to get on a bus and take 2 or 3 buses to get to the nearest clinic, but even in areas where clinics are geographically close by, but for whatever reason, a schedule, someone works 3 jobs and they just can't get to a clinic. Providing a degree of care, keeping people healthy, keeping people well, keeping people at work, keeping people in their homes. This is something that benefits everyone. And so my hope is that the payer community will continue to expand its policies after the COVID crisis is over. All that said, to your point, yes, we've been preparing for this for a long time. We provide not only video visits, but we also have mechanisms that have advanced sensor capability that many of our patients have today. We have a little over 1,000 patients that have a TytoCare device today. And that device allows us to take vitals remotely and load them directly into the electronic health record. The patient can use the device at will and have those vitals loaded in any number of times throughout the day or night. we can use that device as part of a virtual visit or not. So we've found in the last, couple, 3 weeks, we went from having, I would say, I don't know, a couple dozen providers that took care of virtual visits for us to 2,500 trained physicians who are excitedly seeing their patients, staying connected virtually with those patients and keeping those patients healthy and out of the acute care facilities. So it has been inspiring. It's been wonderful to see the appetite that exists on the part of the patients to continue to receive care in this needs. And it's been so inspiring to see how quickly the physician community and the advanced practitioner community just flipped, like flipping a switch and just said, okay, here we go. And so, as is often the case in a crisis situation, we get to see the best in our colleagues as they step forward and do things very differently. With constraints that they're not used to having, and excelling and finding a way to do the right thing. So it's been a lot of fun.
Yeah, sorry.
No, please go ahead.
So to that point, we've just mentioned from both perspectives, the cultural adoption, the health system adoption, the regulatory adoption, the payment adoption. We've effectively, leapfrogged our historical into this new world that, from a digital health leadership perspective, we knew was inevitably going to be here. We've been preparing in some cases more than other. We know that technology has not been the issue, and now we're here. And we're here, and we're really just, I would say, scratching the surfaces of possibilities in today's, with today's capabilities. What does post COVID-19 look like? How do we all go back, if we do, to the way healthcare was delivered, or is this a launching of the future now? Angela, we'll start with you and then move to Sujoy.
I mean, I think it's the start of a new normal. I don't think there's any question of that. The closest parallel we have is back when, over the last several years, most workplaces in the United States have found a way for corporate or back office employees to work remotely. They've done this for a variety of reasons, whether to win the war on talent and be able to cherry pick talent from anywhere and not care about where they sit, or they've done this because of real estate costs and considerations, or any number of reasons. And we saw many years ago that there were a lot of people in the workforce that just didn't feel comfortable working remotely. They didn't feel comfortable like this. They really needed to be face-to-face in the office, or at least that's how they felt. But once they were exposed to this new capability and just, were told you will be working remotely, some number of days a week, suddenly they realized that in fact they can be extraordinarily productive. You take that bloat out of your day that is usually taken up by a commute and or ironing your shirt or whatever. These things add a lot of extra time to the day. And so remote work has been broadly accepted and supported now by most folks in the community in the US. So that's, where it's possible. And so I think it's a similar phenomenon, but with a greater accelerator. Now we are all now operating remote, or under extreme conditions, not remote. So with that, new habits are formed. A new level of comfort can be had. And I certainly think that it will become less of an acceptance and more of an expectation over the next handful of weeks. I mean, the idea of having to get yourself into a physician's office to see your practitioner, it will seem overwhelmingly heavyweight, particularly as advanced sensor technology continues to proliferate the consumer market, and as health systems are able to incorporate that capability into their broader service offerings so that the consumer doesn't have a fragmented experience. So as those sorts of things continue, it'll just become an outrageous imposition to go in.
Yeah.
In some case, I mean, for some things, right? For some things that require equipment and, a physical presence, then of course you would still want to be able to provide that to the community. But I'm looking very much forward to seeing a better health equity and availability and access play through digital means in the new normal.
I love that. And naturally, as a clinical informaticist, Sujoy, with the diffusion of these sensor technologies, with the new normal being backed by technologies that are collecting data in droves, and we have now what level of new intelligence to layer on top of to further advance prediction, prevention, and the rest. What are you most excited about? What are you seeing as the new normal? And again, as it becomes very accessible now to all of India, this has got to excite you and have your wheels spinning as an informaticist as well as a caregiver.
Michael, I can't wait to give that answer. And I would give that answer in two ways, right? And the first one would be a bitter pin. The way we have looked at this, the conventional epidemic management across the world, particularly looking at healthcare institutions at the centerpiece, right? Today we have at the front line doctors and nurses with all kinds of PPE going and working and saving lives without even considering about that. That needs to be changed. That needs to have a complete relook at the levels, at the different levels, starting from the topmost organizations in the world to the levels of the hospital boardrooms, where people need to now realize that they are not going to do an epidemic drill with 10 or 15 people coming in the hospital. We are now having hundreds and thousands of people coming in the hospital at different ways and, meeting their fate. So that is a fundamental change that I am looking at from a policy perspective, from a change perspective that we need to look at in healthcare system across the world. And we must prepare better. Right? I mean, there are these things are fundamental. PPE is fundamental, right? For any kind of these things to actually come. There are lots of other things. I don't want to go into that. Infectious disease being my primary discipline, I can go on and on that, but I don't want to delve with some of the controversial things here. From a data perspective, we need to be very sensitive at this time about PIIs, personal identifiable information. And what we do with the data is also very, very important. I think, back at Sloan School, we were always taught about looking at things within a systems thinking perspective. We need to bring in system thinking in healthcare. We need to look at how we focus in the clinical care with associated data, particularly around the COVID example. We need to look at how symptoms are evolving. What are the early warning signs that we are getting out of people who are, going into a quick deterioration over a period of time? There is a lot of controversy around the world, and people have done a lot of things around this. When to test? Clinically, and this is where data can help. The treatment protocol. Today, we do not have a universal treatment protocol, 100 days into or more than 100 days into an epidemic, right? I mean, we are so-called 21st century at this point of time.
Right.
And then there is a lot of ways that we are actually go and look at the emotional health, reassurances, right? That is from individual perspective, from the patient's perspective. Then again, when you start getting the public health data, look at the heat maps. A lot of people look at heat maps of where the cases are coming in. We need to go 2 steps ahead of that and look at high-risk zones. Another 2 steps ahead of this, identify people where you have huge amount of elderly populations, preconditions like diabetes, heart diseases. These data are available with us, with health systems. And they need to now come out. We need to have modelings around those. If you look at today's SIR model that is going around across the places, they are not specific to some of the populations. There are models which are specific to elderly and other populations. But in general, if you look at the SIR model, they do not talk about this. So people who are at the high risk of exposures, and then go into that. Lastly, I'll just talk about, a little bit of course, whether it is right or not, or come back to that question. How do you design services around this, right? Because we have been too much of defensive with this virus. We have to now move ahead and smarter than it. So whenever you have time, we'll talk about that.
Well, thank you, Sujoy. I think, what's kind of surfacing right now, again, as we look at data as almost fuel to the possibilities that are before us, what is the relationship and what is the role and what are the new economic and or regulatory narratives around edge data, patient data, the limitation right now of interoperable or universal data sets and the comprehensive determinants of health that drive my health and the community in which I live in. Sujoy, you mentioned a number of times the ability to isolate aging, comorbid, and the rest. At the end of the day, this is going to take a level of engagement from me as an individual, from my community, and the trust in the system and the understanding that that data is accessible but not taken advantage of. Can you envision, Angela, maybe I'll kick it over to you for a moment, as we're looking at the U.S. that is very decentralized and incredibly fragmented and has data silos all over the place. And again, Sujoy, I say this with a little bit more knowledge on the U.S. system than India's system. But Angela, what do you see as the opportunities and challenges in data usage and data value?
So that's a big question. So there are a few things. Number one, every patient's record is, we secure that record vigorously, but the patient can share that record with any other entity with a click of a button on our app. So if they choose to share that data with another provider with whom they're engaged, they can certainly do that. It's very, very easy. Likewise, we have data, of course, on our populations. We have the communities that we serve. We pay very close attention to population health, as you can imagine. But we're not, we're not secretive about that data. That's data that is broad and it's something that we use as we think about where we're going to next invest in the communities that we serve, so that we can certainly provide the level of access to care and the level of quality of care that is needed. And how do we know what's needed? Well, it's this sort of analysis. As it relates to the more interesting analysis, generally speaking, I'll tell you that we have an Institute of Innovation and Artificial Intelligence, and it's co-led by our Chief Medical Officer and by me. Our Chief Data Officer plays an administrative role in that. And many of the AI-based solution sets that we've incorporated into the broader estate are coming out of that institute. It allows us it provides a mechanism by which we can very quickly evaluate and experiment with emerging technologies, emerging algorithms from a variety of institution types. So, research institutions, universities, startup community, other large entities. We do a lot of collaboration and co-creation with other entity types. And largely all of the innovation, I won't say every single piece of innovation, but the vast majority of the innovation coming out of that institute, it's based on better analysis of data, extraordinarily advanced analytics. So that's certainly going to have make a huge difference in the quality of care that we provide and that everyone provides over time. The proliferation of this data and our ability to get our hands on it and do something interesting with it, I think is directly related to how the level of care that we provide over and above what the traditional levels of care have been. And then, of course, as it relates to a more, dare I even say, a more personalized approach to care, then, of course, it all hinges on having that view. There is something that you said earlier to Sujoy, and I wanted to tack onto it a little bit. As it relates to this COVID-19 crisis, I've found that there is no such thing. There is no value in having our own models that we're not sharing and discussing with other systems that are supporting the same communities. I shouldn't say there's limited value. So we are working extensively, not just in the deep modeling activity, validation of assumptions, understanding the models to run. We have crafted those models jointly with other systems that are in the same communities, and by the way, with emergency response organizations, and with the counties we serve, with the fire department and police department and the medics and everyone else who's serving the same communities and preparing to respond to a potential overrun. So these are times when we are working not alone, not in silos, but all together, bringing the best minds to bear.
Well, it really amplifies the title of our web series, COVID-19 Unites Us All, right? This is absolutely no time to look at profits over people. We need to orient naturally on the well-being of our communities and our people. When we look at the data at all, and you're looking at building clinical decision support, AI, deep models, and Sujoy, this is going to kind of anchor us on our first conversation together in Montreal. The access to data sets that are universal, let's say comprehensive, include all people from various backgrounds, various socio-demographic, et cetera, allow us to build more robust models, correct? Less bias involved. What back to this being a crisis that's leading the charge in collaboration. How do we move forward in accelerating and amplifying that data sharing, accelerating and amplifying our universal knowledge sets to build for our communities? Sujoy, I know you've done a lot of work right now across the globe with building these partnerships and seeking the development of this type of data lake, or call it what you will. Can you share a little bit more on that?
Yes, Michael. Again, very, very important perspective, where actually international consortium, or as we term this, is going to be so very important at this point of time. And it's not just about clinical data, but it's also associated data that we get from healthcare or healthcare systems at this time. Michael, you have the entire, or we have the entire DHIT community with lots of innovators, technologists, entrepreneurs, and brilliant people, brilliant minds around this. I have few suggestions here, about 5, 6 of them, to actually hold on to that in that way that, how do we go about this, and what are the different perspectives that perhaps we need to look at. First one is about communications. Today, if you go around and if you look at social media, if you look at communications that come from different sources, some of them are authentic, some of them are not so authentic. So the first thing that we need people to actually work on, if you AI scientists, data scientists, or people like that, is to actually work on factual communication versus the misinformation that goes around there. right? And that could be also life-saving in many, many ways. There are a whole lot of treatments that people have been promoting in one or the other way, which people might have tried and they might not have got the desired results. So look at it from that perspective. Second is, we know that world over we have the best sort of work happening around supply chain logistics and all of that, but haven't we found short of doing that, right? If you consider it in terms of PPEs, masks, and ventilators, we still have to really look at their distribution, their production, and see, such things do not happen, or going forward, we can do better on that. Critical interventions, you talked about CDSS and all of that. I think one of the most important thing is, identifying early warning signs and appropriate follow-ups of these patients. Because today, if somebody is giving you a 70-year-old who have had a contact, and he's giving you something like, a history of a mild fever and, cough at this point of time, we need to get back and ask him, right, that is there an early warning sign that is developing in next 24 to 48 hours? And these are systems which can actually help us in doing that. Community engagement, tracking and tracing, which is conventional, epidemiological modeling, and I'm not a very good supporter of flatten the curve concepts, because you don't flatten the curve to make a 5% mortality virus to live in an endemic zone in the world. You cannot do it, very simple. And then, of course, there are multiple other ways in looking at drug discoveries, vaccine discoveries, where people may come over and contribute. But finally, and most importantly, I think we need to now have systems, digital health systems. We need to have more and more research, more and more intense understanding of psychosocial support that we would lead to the people coming out of this trauma across the world, right? And this, these are 5-6 areas, and predominantly the last one is the most important in my list of things, where we are able to lend people with supporting hand while they combat for this particular virus.
Thank you, Sujoy. Angela, do you want to comment, piggyback, add to, from the perspective of Novant and yourself?
Not at this time. I think Sujoy has covered it nicely.
Okay, wonderful. One last question as we before we turn over to some Q&A from the audience, who've been very active. Considering, again, your point, Sujoy, of the innovation on the entrepreneurs, the technologists, the advancements that will come from this opportunity. Where do you think, coming out of this, where should our DHIT community right now focus, perhaps on building solutions that are in need, perhaps right now or immediately after this pandemic? Is there anything that comes to mind from a technology, digital health innovation perspective? Angela, maybe we'll start with you and then close it out with Sujoy before going to participant questions.
Sure. I mean, I would encourage, if I were to think about the community here on the call, I'd imagine that you have, a number of innovators, and I would say to those innovators, think about ways in which advanced sensor capability, the unprecedented access to data that we have, the ways in which we can now communicate and stream data. Think about ways in which that could be brought to bear to support digital health in a remote location. I mean, as you already have. And I know there's a lot of fragmentation that exists in that landscape, and there, it can be even confusing to consumers because there's so much, so many wearables and other ways in which we can track our own wellness and health. But the more, I think the more options that exist, the greater appetite will be, and I think it will certainly provide provide greater access to care for patients. For the healthcare systems that may be with us today, it is our responsibility to make that fragmented universe one. Provide a way to allow for tremendous interoperability with all of these devices, with other systems, with third-party entities that can come together as part of an ecosystem to provide care to our patients and our communities. That is how we get to health equity. That's how we get to access for all. And that, by the way, is how we get to lower cost of care. So, everyone wins if we can make sure that we continue to focus on that interoperability and that bringing together of an ecosystem for one way for a patient to engage, even with all of these new devices. And then if we have people from the payer community here, again, this is how we bring down healthcare costs. Keep doing what you're doing. This is going to be big, and let's work to define the new normal together. This is the time.
Awesome. Thank you, Angela. Sujoy?
Yeah, I would put it in a very short way. I think, we talked about the international consortium, and that is exactly where you actually, bring in a complete defragment the whole thing. And then build models, validate, calibrate, deploy, come back again with more data, model, validate, calibrate, deploy. And that is the kind of cycle that we would need to now move on to, which would help healthcare systems across the world in these trying times.
Seems like what you're alluding to an extent is a universal standard and operating practice. And it's certainly, one of the participant questions I'll read because it gets to this to an extent. It says, with all the data visualization tools out there, it seems like every day we see a ton of new COVID graphics, forecast, projections, community vulnerability maps, et cetera. How much credence can we give to what we're seeing in terms of accuracy and validity of what is being presented? And I can only imagine, and this, I'll just read one more from the audience that says, now that the integration of digital health has been kickstarted by this tragic pandemic, what do you believe will be the greatest challenges faced by the people who have been driving this industry over the past years? And from my perspective, I'll just maybe tee it up and with my immediate knee jerk, but it's the gold rush that's inevitably going to come of a burgeoning market and the noise that we're seeing of trying to profit over the pandemic. That's what I see as one of the greatest challenges that we're going to sift through and sort through, and back to universal standards, back to unifying in the order of people over profit. What are your thoughts, Angela? What do you say to
okay. So my first, have you read anything about the fate of the rural hospital? I mean, we're a large system, but no one's profiting over this pandemic. I mean, this is costing every system a lot of money, and will for a long time, to the point where I'm sure you've seen the articles that some of these small independent hospitals in rural areas will not last another month or 2 months. They'll be done because they just can't make money. And the pandemic is not, there is no way to profit off the pandemic. It is a disaster any way you look at it. So that said, I believe that I would say to the people who have been in the digital health space for a long time, this is an opportunity to create new alignments. This is an opportunity to create alliances with other healthcare entities. This is an opportunity to create a holistic digital care suite for our patients. There is a way to provide care in a way that can be within an acceptable cost structure, that is maintainable, and that can pay for itself. No one's going to get rich, but it can pay for itself, and it's the right thing to do for the communities. That I think we can define together. We are fortunate that we had a bit of a head start over the past, several years, and we've consistently, year after year, invested in the latest capability sets that are available with the advances of technology as it's come. So and we have the capability to train very quickly. When I said we had 2,500 physicians. We train them within a couple of days. This is because we can do that. We already have, we're not trying to figure out how this is supposed to work. We already have that defined. So If you're in a world in which that find yourself maybe about to disrupt the environment, think about the long-term play that you're going to make, because the short-term play, you may be able to make some money, but there's a long-term expense associated with providing health. And so figure out who your big partners are going to be to allow for your health, your company's health over time. And anytime anyone wants to talk about that with me, I'm happy to have that conversation. That's a fun one.
Awesome, Angela. Sujoy, any thoughts?
Yeah, I would flip the word profit to value. And we need to start seeing value out of this in one or the other ways. Michael, one of the important ways of looking at it, it is going to be definitely difficult for health system to sustain this for a long time. Any health system, and that is exactly why I said sometimes the model of flattening the curve may not be sustainable in the way that, particularly in the pockets, or even in pockets in big cities, pockets in rural areas across the world, and it's going to be such a burden. Because we all understand value very simply in terms of outcomes and costs, and if the cost goes up, right, both in the terms of money and in the lives lost, there's very little that you can do about that. So we need to start looking at it from a completely different perspective, where we have to see now, and that's where data is so important. That's where we need to now look at what's going on, because today, whether and I've been looking at Lancets and NEGMs and JAMAs and all of the other awards, but one thing that must come out by this time in the life of this pandemic is that we need to now, in maybe next week or so, identify a proper regimen where we need to start saying, hey, look, this works. And this is something that we are ready to do globally and try and do it to, do whatever to save lives at this time. And therefore, that is what is actually going to change the equation of the value around it and put more onus on outcomes and reduce the cost in that way. And where the digital health helps in is actually in the way that, the accessibility, taking it to the last mile, as I said in the beginning, is going to be very, very important. And, particularly in India, as we start seeing cases in the rural areas, this is going to be very, very important.
So, and this ties to another question from and/or statement from the audience. Do you see? And I would have loved to have Kathy from Montreal included in this, specifically because of the nature of a universal healthcare system, a nationalized one-payer model. Do you see some maturing and/or I shouldn't say maturing, but evolving into payment models that are more akin to universal payment and universal care, or are we looking at a hybrid? I mean, as we look at value and we look at payment model reform, if you will, and caring for our community from a universal N of one, the payment structure has to change, no? And is the universal model more, set up for success than where we have, in the US and India from a decentralized perspective?
Well, I mean, at this time, I would say we are still evolving with the payment models as such in the country itself. Only about 17 to 20% of our total patients are insured. The rest of it is out-of-pocket expenses. So you can very well imagine the load that it actually have on India in terms if it is going to sustain for a longer period of time, or if it's going to go for, say, months to come, the enormous load that it will have it on our that. But from the other important aspect, if you look at private hospitals and all of these, these are the times, as Angela pointed out in the beginning, we are not doing our conventional routine cases. And we do not know how long to actually push them, from a clinical need perspective also. How long are you going to say that the patient who has an uterine fibroid or a patient who has a gallbladder would not require a surgery, right? And, we know that both of these can turn sinister over a period of time. So there are very, very important questions that have to be looked at, seen through in the health systems. And I'm sure these are things that are going in the minds of people who are making decisions for hospitals or for the country as a whole.
Thank you, Sujoy. Angela, any
Yeah,
thoughts?
I represent just one entity type in the vast ecosystem of parties who are involved in that sort of future state planning.
Yeah. Well, thank you both. Angela, Sujoy, again, incredibly humbled, honored, and delighted for today's discussion, your support for our community in discussing and diffusing perspective from your health systems, from yourself, to help mature and evolve our thinking and our actions. I'm incredibly blessed to have had this conversation with you. I really do appreciate it. I wish you and your families and your health systems and your communities the best through this pandemic. I do encourage a continuation of engagement with DHIT, and naturally, I hope, Sujoy, Angela, there might be a relationship between your two organizations as we mature as well. Would be happy to facilitate further conversations. Thank you so much. As we wrap up here, I've got two notes. One, again, thank you to our sponsors, Blue Door Group, Tanjo, and Smashing Boxes. We are a nonprofit 501c3 public charity. We do not exist without the support of our sponsors and our donations. If there are any corporate entities out in the audience today that would like to carry on sponsorship, please contact events@dhitglobal.org. As well as for the audience at large, please save the date, April 17th, for our next webinar under the continuing theme of COVID-19 Unites Us All. Again, Angela, Sujoy, great pleasure, many thanks, and wish you well, health, and positivity through this pandemic.
Thank you.
Stay safe.
Likewise, cheers.